I'm not sure. Can everyone hear it at the back? I'm not sure if this is working. But right. Hi, my name's Anna. I'm one of the FY1s in infectious diseases over in Jimmy's. I'm also on the committee for Countdown, in charge of the website and all the IT. Thanks so much for logging on. Thanks for liking the Facebook page. We're trying to keep everything really up to date to keep you guys informed of any changes that we make. Almost all the resources from last week are on the website. There's videos on the website, presentations. So have a look at those, download them, print them out. I'm going to try and get some of the handouts and things on before the lecture, because it's getting quite expensive for us to keep printing lots of stuff out. So you can download them and print them off and bring them. Other things to get involved in, if you've got any questions, I know with jobs coming up, just general revision stuff, we've got loads of FY1s who are using the website as well. So if you want to post any comments on the Facebook page or the blogs, they will get answered. And sometimes, like near exams, it helps to kind of brainstorm a lot of things. There's always a lot of rumours going around. So, we've got a lot to cover this evening. I'm going to be really quick, but hopefully give you a good overview that will prepare you for your finals, give you a bit of basic knowledge to build on, and also really prepare you for FY1, because that's ultimately what it's about. So, where's my mouse gone? Here we are. So I'm going to be doing upper GI bleeding and acute abdomen. My first job was gastro, so the first part is my bread and butter. It's what you'll be dealing with as an FY1 if you do gastro. And the second part is such a big topic, but we'll try and cover some of the general principles. So as I said, we're going to cover some basic causes for each. I want you to become confident in clerking, know how to take a focused history if you were given a time limit, knowing exactly what questions you need to ask. Appreciate what you should order and how you should interpret those and present them back to your seniors, and understand how to initiate the basic management, so keeping the patient alive until someone else gets there to do the big stuff. That's basically what your first year is about. So you've got a bit of a handout which is kind of a real précis of what I've got here, so we can keep the interaction to a minimum if you prefer. Okay, most common causes of upper GI bleeding. You've got them on your handout. What's the biggie? Anyone? Yeah, ulcers, absolutely. So they're on the top. And often, kind of below that, you've got a lot of the gastritis things, which comes with the ulcers. You'll see a lot of variceal bleeding, because you'll see a lot of alcoholics. And then towards the end, slightly rarer, you get a lot of Mallory-Weiss tears. And the rarer, but the ones to definitely not miss are the malignancy ones. Now, red flags for malignancy. Does anyone know what kind of questions you want to be asking regarding upper GI malignancy? Weight loss, yeah?
Difficulty swallowing.
Yeah, dysphagia. That's really good. Yeah, so that's a good one for esophageal cancer. That's progressive dysphagia. Anything else? Yeah. Then there's things that you might not think about, anemia, obviously bleeding, and just vomiting that doesn't go away. So really quickly about peptic ulcer disease, that covers both gastric and duodenal. Duodenal are more common than gastric, however gastric are kind of more suspicious than duodenal. Risk factors for both are very similar. H. pylori is a causative organism in a high majority, so you've got to think about that in the first presentation and rule it out. Other things, smoking, non-steroidals, because of the way they can affect the stomach lining and affect prostaglandin synthesis. And things like aspirin, warfarin, anything that's going to increase your chance of bleeding as well. And does anyone know anything about Zollinger-Ellison? It's a bit of an eponym which is like, yeah, so it's so basically involved in, you get these tumours around in the GI system in the pancreas that produce lots and lots of gastrin. So more gastrin in the stomach means you're kind of more prone to more ulcers. So the things, you probably know how to take a good GI history, but you don't want to be missing asking about epigastric pain. Characters can vary, so classically in exams you're thinking about how it associates with food. So with duodenal ulcers you get a pain which is worse than hunger. However, with gastric ulcers, you get pain which is worse during eating, and it's all just to do with how gastric acid is secreted in kind of anticipating food and receiving food. Other things, so your weight loss and your anemia are good for the malignancy, and also can indicate if you've got a bleed going on, even in a very stable patient. Investigations you want to be doing for peptic ulcer disease. There's lots for H. pylori. Quite commonly over in Jimmy's, we often did an OGD and took biopsies and found out that way. But you're probably aware of the urea breath test, which is also quite a common thing they use. And you can also look for it in the faeces. The mainstay management for peptic ulcers is PPIs, so you're reducing the amount of acid in the stomach. People on those long term, classically lansoprazole, 30 milligrams a day, but it depends on severity of disease and how well the patient tolerates the medication. Triple therapy you might have heard about, that's for eradication. That's a 1-week course of 3 agents, a PPI and 2 antibiotics. I've put metronidazole there. It's actually amoxicillin. You'd use metronidazole on anyone who's allergic to penicillins. So it's a week's course of that. That usually wipes out the H. pylori. Complications of peptic ulcer, we'll talk about a couple of these later. So perforation, that comes in the acute abdomen bit, hemorrhage and your malignancy. As I said, the gastric ulcer is more likely to become malignant than duodenal ones. So you want to be repeating your endoscopies as an outpatient just to make sure that they're healing okay. Mallory-Weiss tears, so it's what you get in the exam is something like this. They'll pop in a medical student who's been out too much, lots of vomiting, then suddenly brings up a large bright red vomit, and they're perfectly fine apart from this. And it's just a small tear in the esophageal mucosa. And normally it spontaneously resolves. However, if you get big tears, you might need to actually stitch them up during an OGD, but that's very rare. So that's a classic question to get in an MCQ. That's meant to say esophageal varices, sorry. Esophageal varices are very common in people who've got portal hypertension. You see them a lot in alcoholics or people with other chronic liver disease. With portal hypertension, you get blood flow directed to lots of the regions of the body. One's the esophagus. You get also gastric varices, anorectal varices, and dilated veins on the abdomen. So as the blood flow is directed to areas of lower portal pressure. Causes, break them up. Think before the liver, in the liver, and after the liver. Mostly it's hepatic, so it causes cirrhosis. But you also got to think about thrombus of the exit veins to the liver, and that's where Budd-Chiari may come in. You don't need to know much about this, but you just need to know kind of vaguely what these terms mean. When looking at these patients, you want to be looking at the whole system, looking for signs of liver disease. You know the basic ones, but also look at things like platelets and splenomegaly, which you might not think of straight away. And deranged LFTs and the clotting is a really important thing to monitor as well in these patients. So that's what you see on endoscopy. These dilated points are massive varices. They don't look like they're bleeding at the moment though. So, what are we on to next? Presentation. Hematemesis can come in lots of different forms. You'll get nurses come up to me saying they've passed a lot of coffee ground vomiting or fresh red, and it often gives you a good clue about the potential cause, especially if you haven't seen the patient before. And it all just depends about whereabouts in the GI tract it's come from. So it makes sense that Mallory-Weiss gives fresh red blood because it's from the esophagus, whereas gastric and duodenal ulceration, you've got some acid change to the blood, so you're going to get a slightly darker. It's classically coffee ground, but you've got to be careful because patients learn terminology and can convince you. Melena is changed blood that passes through the GI tract. It can be for any of these causes. So if you've had a significant bleed, but it's not enough to cause gastric irritation and cause hematemesis, you can pass a lot of melena, usually 24 hours, a couple of days after the actual bleed. If you have had a massive hematemesis, it's likely you'll have some melena a couple of days later as well, just as the blood passes through. You won't forget it if you smell it. It's not very nice at all. And unfortunately, blood's a really good laxative, so it's not just solid store, it's everywhere. Other things in your history to ask about if you're keeping it nice and focused. So, obviously pain, but you want to be thinking about anemic symptoms. So that's where your syncope, fatigue and shortness of breath come in. And make sure you cover those red flags as well. In past medical history, you want to be asking about GORD, any known hiatus hernias, any known alcohol excess or chronic liver disease. And it's really useful to ask, have you had this before? Have you had any camera tests? Because it gives you lots of good clues. In your drug history, you need to be ruling out causative agents, so you need to be asking about aspirin, warfarin, clopidogrel, that kind of stuff. NSAIDs as well, and iron tablets, because iron tablets make your stools black, so it's useful to know, especially in a patient who's newly onto iron. So examination, do a really good GI examination, but look at the observations. They give you lots of clues as to how stable the patient is. A lying and standing BP is very, very helpful. You're looking at, if you've got a drop of about 20 systolic, you need to be quite worried. Look for anemia, look for dehydration, and do a PR, because the registrar only asks, why haven't you done it? Investigations, so blood tests, we covered it a bit last week. HB is obviously important, and urea is kind of the second most important standard blood test. You look for a high urea because blood's protein, and so you've basically had a big protein meal when you bleed. The LFTs and coagulation, as I said, gives you an idea about liver disease, and then you need to be thinking about definitely group and saving. If they're really unstable, you want to be cross-matching as well. Other investigations to order, an erect chest X-ray, especially if they're in a lot of pain. You need to be ruling out perforation. So what you're looking for on a chest X-ray for perforation? Yeah, air under the diaphragm, that's good. ECG as well, because MIs can present in unusual ways. You can get kind of radiation of the pain. It's worth ruling out. And then eventually you're probably wanting to do an endoscopy. Depending on how acute the situation is, depends on at what point you do the endoscopy. So, this is a good apt condition. So this is not an unfamiliar situation you can find yourself in next year. So you're a gastro FY1 clerking in SAU, which is what you do in Jimmy's, which is a bit bizarre. Your next patient is a 47-year-old male with a background of rheumatoid arthritis. He's presented with new onset severe abdominal pain, and you're just reading through his notes, getting his bloods from A&E, that kind of thing. The nurse in charge comes and asks you to immediately assess him, and as soon as you arrive, you witness a massive dark red hematemesis. We're talking big volume. What would you do? Good. So, A, maintain the airway. B, give oxygen. Get your observations regarding respiratory rates and SATs and things. What do you do for C? Yep. So you want to get some access. Access is sometimes harder than you could say two. Well, ideally you want 2 large bore cannulas, but that's harder than it is to say. I'm struggling. Good. So fluid challenge. So you're looking at the BP. If they've got a big systolic drop, you're thinking about fluid challenging. We're taking off the bloods that we said we'd do. We're cross-matching as appropriate. If he's massive hematemesis, you want to be getting some O-negative blood as well, getting it straight to the patient. In the meantime, for D, you want to be getting an idea about kind of why they're coming in, doing a quick examination, GCS, glucose, you all know this, but it's all kind of important. And then you get some help. So that's a kind of typical observations that you might get for a patient, which is quite worrying. And then something like those blood results where you've got quite a bit of a drop in your hemoglobin and a raise in your urea. it's important to follow ABC, but also tailor it to your patient. So not everyone's in an acute dire situation where you want to be getting 16 gauge cannulas in them, but it's useful, especially for exams, to know exactly what you do and feel calm in ordering all your investigations. So keep the patient alive with A, B, C, D and E, then think about the bloods and the investigations you want to order. So keep them stable if they are stable, and do things like this. This is just general considerations when you're clerking a patient. So if they're stable, you've taken your history and examination and you're comfortable that you think you know a diagnosis, but they're not going to become really unwell on you. You can spend some time ordering your investigations, treating their symptoms if they've got any, and then planning for their stays, so stopping any causative agents, not putting them on any VTEs, keeping them nil by mouth for their endoscopy, considering fluids, and that's kind of fluids, slow fluids, not necessarily fluid challenge. Consent for a possible transfusion and get your bloods sent away for that. Consider your other investigations, and then if you're comfortable that they're still stable, you can go to your registrar with all the information and say, well, I've got all this information, and they, you can sell your case to them with convincing results. So other bits and pieces you need to be aware of, but these are mainly senior-led. Terlipressin. People come across the use of terlipressin on wards and things. It's used quite regularly in patients with esophageal varices. It acts to vasoconstrict, so to reduce portal pressure, reduce the dilatation in the esophageal varices, and hopefully stop the bleeding. It's given as given IV as an infusion over 5 or so minutes, and you tailor that to your patient. Do you know what you've got to be careful about with terlipressin?
If you give it slowly, like over 5 minutes.
Yeah, give it slowly because it can irritate. Anything else?
The confusion.
No, I don't think so. It's to do,
Other problems.
yeah, other comorbidities, so heart problems and peripheral vascular disease. Because if you're reducing pressure in your vessels and you've already got poor perfusion to your limbs, you need to work. You don't want to be given terlipressin, basically. Another big thing is OGD, and they do various things depending on what they find, how big the ulcers are, how big the varices are. Ulcers tend to get heat treated or glued, and varices tend to get banded. And when they come back up to from endoscopy, you'll be starting them on a 3-day, very slow omeprazole IV infusion, just to protect the gastric mucosa and reduce the gastrin production. Does anyone know what that is? Yeah. So that's a classic, slideshow picture. That's a Senstack and Blakemore tube. That's when you're using that, you're in a very scary situation. For management of uncontrollable variceal bleeding, that may be before endoscopy or after endoscopy if they haven't managed to do enough treatment. You go to ICU because you're intubated, and you have a big balloon down into your esophagus and lots of weights pulling it down, so the balloon presses against the varices just to attempt some form of healing, and then you go back down and do another endoscopy and see what you're dealing with when the bleeding's last. Other things you might have heard about are TIPS. They're quite regularly done. It's a transjugular intrahepatic portosystemic shunt system. Basically, you're bypassing the liver. So anything that's causing the increased portal pressure, such as cirrhosis, you're bypassing that. So hopefully you're reducing the portal pressure, and you'll stop bleeding in the future. What's the risk of a TIPS? Does anyone know what you need to be careful about? Pardon, what's that?
Encephalopathy?
Yeah, encephalopathy, because you're bypassing the liver, so the liver's not filtering out your toxins, especially the ammonia. So you've got loads of ammonia going around in your blood, and that can make people encephalopathic. So if you see patients basically who have a history of encephalopathy don't tend to get the TIPS. Good. Post-bleed management, so stuff you'll be doing on the wards and you've got to think about. Break it down: conservative, medical, surgical. So people got to stop drinking, avoid regular courses of NSAIDs, look at different ways they can manage analgesia. Medical, people will go on PPIs as we talked about. People with chronic liver disease and varices will go on to propranolol, which is a beta blocker. That's very good at reducing portal pressure as well. Often you'll pop people on antibiotics, mainly to cover for SBP. Are people familiar with SBP? It's a spontaneous bacterial peritonitis, which is common in alcoholics, especially because they've got a reduced immune system in general, and anyone who's got chronic liver disease for any cause is quite prone to infections. And surgical, interventional, you want to be thinking about repeating an OGD as an outpatient to assess for healing of gastric ulcers because of the malignancy. Just something I've learned in the last couple of months being an FY1, you've really got to think about your patients, especially when you're chasing bloods for patients that you don't know. So this is a patient that we had on gastro. You've got a bit of a background, thinking maybe what's going on, and you check his bloods and you get a bit scared by that. Always click on the trends button. It's really, really useful because that's his trend. So he's never really been anywhere above 9. And if you look at that, his renal function's just been this. I mean, it goes back to November, but it goes back years. So you don't need to jump in there thinking, oh, he's got AKI, he's having a big bleed. Just look at it. The potassium and the sodium are because he's on high doses of spironolactone. That often happens. It can be a vicious circle, increasing spiro. You get high potassium, you just constant cycle. And the urine creatinine give you an idea about CKD. And that's his chest x-ray, so you don't want to be piling loads of fluids onto him. So it's just something to think about, and you don't think about it until you become an FY1 and start panicking about every blood result you chase that's red. Look at the trends and you'll kind of get a better picture of the patient. Okay, so we're rapidly flying through. I'm aware of the time. Anyone got any questions on GI bleeds?
How quickly would you get OGD for a patient with GI bleed?
It depends on how they present. If they're really unstable and they're in resus, your senior will be there and dealing with it, and they'll get an OGD as soon as they can. With people who sound like they've had a bleed, they've got some pain, they've got a previous history of bleeds, their HB is a bit low, but they're very stable. You're thinking about, well, as soon as there's space, usually the next day, put them on the top of the list and things. Obviously, if they get unstable, you need to be getting them in soon. So you just really, really tailor it to your patient as well. And you've got to keep them tend to keep them nil by mouth for an admission. At least you ask them to be nil by mouth, so your registrar can make the decision about when they want to do the scopes and things. Anything else? I know that was really quick. Learn the ABCDE. It's very similar to everything else. Have an idea about PPIs and things that the registrar uses, like terlipressin. Yeah.
Once I've had triple therapy for eradication, how long do you keep them on a PPI for?
It can depend. A lot of people are just on for lifelong. If they've had kind of a chronic history of ulcers, they'll be on for lifelong. It really depends. It can depend on the consultant as well. Good. Okay, acute abdomen. This is a massive topic. I've tried to cut it down, so we're just looking at general principles to think about. Some of these things might seem like basic things, but if you get them in your OSCE, you'll get all the marks. And if you think about them when you're doing your MCQs, you'll be able to think about it logically and think about why you're doing tests. That's always important. It's not just knowing the tests, it's knowing why you're doing them and how to interpret them. A lot of the things are going to be covered in the other lectures, so they might seem like there's a few gaps, but they will be covered. So you've got vascular lectures and biliary lectures and things. So acute abdomen is a big surgical problem that you'll come across. Treat it like you would treat any clerking of a patient. You need a focused history, so you need to be covering all your GI symptoms that I'm sure you know. Other symptoms, you just need to make sure you've ruled out bleeding kind of from any source, because lots of gynae problems, although that's specialties, not finals, can cause an acute abdomen as well. past medical history is really important, gives you lots of clues. If they've had similar episodes, can give you an idea about what it could be. Previous surgery, scars are really useful. You've probably seen some pictures in the Oxford Handbook, or Google it. You've got a picture of an abdomen with lots of different scars on. Don't learn the names of the scars, just appreciate if you saw them what could be. Just think about underlying structures, really. Ask about things like inflammatory bowel disease, because it's useful to at least rule it out as a cause of a painful abdomen. As we talked about before, drugs specific to causes of acute abdomen, so NSAIDs and things. Social history, alcohol is very important, as you know, for ulcers and pancreatitis. And family history is useful to see if there's any kind of disease running in the family. IBD is really important to rule out, as I said. Examination, you kind of, when you do your things, like, oh, from the end of the bed, I'm just looking for like drip stands and things, but have a look at the patient. You quickly learn that a peritonitic patient is dead still, they're not moving, whereas someone with really colicky pain is trying to get to a position where they can move. It just gives you a bit of an idea, and it shows that you're really thinking about what might be going on. As I said, scars are really important. And look for the chronic signs, not just of GI problems, like the liver disease, but cardiovascular problems that might give you an idea if this is a vascular cause, thinking about AAAs and things. These at the bottom, the kind of classic exam things that might come up. Does anyone know what Murphy's sign is? I had a mumble of things. It's gallbladder related. So it's pain on inspiration when you're palpating in the right upper quadrant. It's quite indicative of cholecystitis, really. Renal angle tenderness is important to, not necessarily for acute abdomen, but keep it into your GI examination. And Rosvig-Skine is, does anyone know? Appendicitis. So you're palpating in the opposite iliac fossa, and that accentuates the pain in the right iliac fossa. So, investigations to order and to have a think about. On your bloods, you've got your HB and your MCV, and that gives you an idea, as we talked about last week, of anemia and what type of anemia. Your urea is good for bleeding. White cells and your neutrophils are good for infection, and platelets are good for infection, and also for any inflammatory response. You'll see a big rise in your platelets. Try and get to grips with LFTs. They're really tricky. I never really got to grips with them, even working on gastro. Know which ones are intrahepatic, so that's your ALT, AST. You don't tend to use AST much in the Leeds Trust, but you use it elsewhere. So they're good for intrahepatic causes. If you're thinking more biliary tree, ALP and Billy. And then your INR and your PT is really good for hepatic stuff as well, intrahepatic stuff. Other bloods you might want to be adding on, CRP, that's good for, as you know, inflammation, any kind of acute response. Amylase, always want to do an amylase on anyone with abdo pain. Calcium is quite useful, especially if you think it's pancreatitis. It's good for a couple of things that we're going to move on to. And as I mentioned before, you want to rule out atypical chest pain. So think about a troponin maybe, or some of the other cardiac markers, just to rule that out. So you've got your differentials and you know which ones are more unlikely because you've got evidence against them. Imaging you might want to do, ECG, chest X-ray, as we said, abdo X-ray, they're really, really hard to interpret. Try and get a basic idea of principles for exams. I think a lot of people really struggle. They can be really helpful, but most of the time they're very vague, they're not taken in the right way. Obesity doesn't help, you don't really see very much of the intestines with lots of tissue. You want to be looking for things like obstruction and ruling out megacolon, which you get in ulcerative colitis. And then think about investigations more appropriate for the organ you think's got the thing wrong with it. CT KUBs are really good for looking at the kidneys, looking at the renal tract. Ultrasound's really good for looking at the liver, looking at the gallbladder, lots of gynae problems, and AAAs as well. And have an appreciation for MRCPs and ERCPs. What's the difference between those? So an MRCP is just an MR of the gallbladder region. You're just looking to see what's there. An ERCP is interventional, so you have an endoscopy and they fiddle around, they can do stuff, they can treat the cause. So often people go straight for ERCP if you're quite sure of what's going on. And endoscopy, as we talked before. It's also important to keep these patients nil by mouth as well. We'll go on to the management in a bit whilst you're doing all this. So I think the easiest way for acute abdomen can seem like a massive topic. Just think about what's below. Think about anatomical structures. That's quite a useful diagram, which will be on the slides. It's got a lot. It looks like a lot, but if you look at it and think about it, I think most of that will come as, you'll probably figure a lot of that out. There are big things, however, you don't want to be missing. These are a ruptured AAA, acute pancreatitis, because that can be really serious, ectopic pregnancies, appendicitis and bowel perforation. They're big things that you want to be confidently ruling out, unless obviously you think it's one of those. And then think about your examination. You're worried about things that come on suddenly. You're worried about patients who are very unstable, who are not responsive. You're worried if their abdomen's really tight and distended. You're worried if they're lying dead still because they got peritonitis. And then a couple of the things like we've mentioned before. So always remember to palpate for your abdo aorta in your GI exam. So I've got a few cases. A 33-year-old man presents with a 2-hour history of upper abdo pain that radiates to his back and shoulders. He's sweaty, he's got a rigid abdomen, he's tachycardic, and he's hypotensive. And if I said he had a background of duodenal ulcer disease or gastric ulcer disease. I think a couple of people, and perforation, sorry, I thought there was another slide. So perforation, classically you get a very peritonitic abdomen because stuff is leaking out into the abdomen and causing lots of inflammation. Causes, we mentioned a couple previously, and also any kind of inflammation of organs inside, especially appendicitis, diverticulitis, that hopefully will be covered in the lower GI surgical talk. An IBD as well, bad IBD can cause some perforation. Symptoms, you'll know this, peritonitic pain is worse on movement and coughing. I don't know why that's there. Signs to look for, tenderness, guarding, rigidity. These are things to comment on whilst you're doing your OSCE examinations, also to think about next year. Have a listen to bowel sounds. Be worried if there's no bowel sounds. So with perforation, your white cells are going to be high, your HB might be low because you're losing blood, and your amylase can be a little raised, although not as much as is usual in pancreatitis. An ABG is often very useful in these scenarios. It gives you an idea about oxygenation, but it gives you an idea about acid-base balance and if there's any metabolic acidosis. And a lactate can sometimes be very useful, especially if you think the patient's becoming septic. So the management of these patients, what you need to be doing is you need to be keeping them nil by mouth, you need to be getting access, you need to be balancing their fluids, thinking about if they look dried, what are the observations doing, how much fluids do they need, do they need a catheter so we can monitor how much is coming in, how much is going out. They often need oxygen, you want to be thinking about some strong analgesia, prescribe a range on the when required part of the drug chart so you don't get asked to come back. Thinking about antiemetics. IV antibiotics is probably something that you'd want to discuss with someone else, but you often see surgical patients on some antibiotics. And then other things you might want to be doing is some closer imaging, or if they're really unstable, you might want to be taking them straight to surgery as well. So just kind of an appreciation for what might happen, so you can try and prep everything beforehand. We talked about something a bit earlier. What's going on? Yeah, this is one of the patients I had in gastro. It took me a while, and then I realised, oh God, his diaphragms are up here. And he had a belly like this, just full of air. Yeah, he didn't do very well. So that's a really, learn that. Look for the diaphragms and look, oh God, yeah. So the next one, 34-year-old lorry driver brought into hospital in a collapsed state with bouts of colicky abdo pain and incessant vomiting of 6 hours duration. So he's tachycardic, it could be a bit hypotensive, it depends what his normal state is. And he's got lots of scars and some tinkling bowel sounds. Obstruction. So that's a very classic. There's things in there which give it away immediately. Obstruction, so think about the structure. You've got things outside. If you think about the intestine, things outside, things in the wall, and things in the lumen that can cause obstruction. So outside, you've got adhesions from surgery. That's a big one. That's why you need to be asking about recent surgery. That's why you need to be looking for scars. Hernias as well. Masses from the outside, so that could be benign or malignant masses compressing the structures. Within the wall, you're thinking about tumours once again. IBD, because you get a lot of the inflammation in the bowel wall, and strictures, especially in IBD patients who had a lot of surgery or people who've had a lot of their bowel removed. The anastomosis often stricture up. And within the lumen, just think simple things. They could be just fecally impacted. They could have foreign bodies. And gallstones as well. You might have heard about gallstone ileuses as well. That's when gallstones, there's a link between the gallbladder and the bowel, kind of an eroded pathway, and you get gallstones travelling down that can cause an ileus. Symptoms, ask about vomiting. If you're really impacted, you could start to be vomiting up a bit of changed faecal matter. Ask about constipation. Ask about, are they passing wind? That's really important to know whether they've got what's called absolute constipation, where they're not passing anything. Ask about pain. Look and ask about distension. It's also important to ask about when the vomiting came on, when the constipation came on, because that can give you an idea about whether it's small bowel or large bowel. Signs, as we mentioned before. It's sometimes very hard to distinguish clinically from the end of the bed whether you've got small or large bowel obstruction. In small bowel, can come on quite suddenly. You get the earlier vomiting and the late constipation because the obstruction is just that bit higher up. On abdo x-rays, you're looking for, does anyone know what valvular coniventes are, what they look like? Yeah, so they're all the way around, they're rings. So on the abdo x-ray, they look like lines right across the lumen. In large bowel obstruction, it can be more gradual. You can kind of get this really just dull, constant ache, and you're more likely to get absolute constipation where you're not passing any flatus either. And that's when you get haustra on your abdo x-ray, which are just the half lines going in, the kind of folds of the intestine. You want to be ruling out ileus, and that could be mechanical because of the stuff like the gallstones, as I mentioned before, or it could just be paralytic because of surgery. Often the bowel kind of stays quite still after surgery. If you've got any electrolyte imbalances, especially potassium, so low potassium can affect movement of the bowel and give you a very static bowel, which may appear like obstruction, but actually you've not got anything in the way. And strangulation as well, so the bowel twisting on itself. They're good things to rule out. You often be able to rule out strangulation and things on an abdo x-ray. The management tend to keep it quite general for both, although you can tailor it depending on if you know specifically what the cause is. They need an NG tube to decompress the intestine, to decompress the stomach, especially if they're very distended. And so that's what we call a Ryle's tube. I don't know if you've seen them. I don't know if anyone of you put them in. They're the big bore NG tubes. They're pretty big. And you pop them in, and basically they just drain out whatever matters in the stomach and the first part of the small bowel. Pop it in like a normal NG. And they want to be, it's called drip and suck because you're taking away the fluid, but you're giving them more fluid through drips and things. Monitor their electrolytes, because when you're giving fluid and you're taking fluid away, they can be quite deranged, so keep an eye on that potassium. Often in large bowel obstruction, you want to know a bit more about what's going on, and if they're stable, they can go for CTs. They can get enemas to know how far the blockage is, how far up the blockage is. And you really treat depending on what you find. A lot of people get better with just a decompression and the drip and suck. Some people need laxatives, remove the foreign objects, stent the strictures, and if it gets really bad, they need to go to surgery. What kind of bowel obstruction is that? Small bowel. So that's a really good X-ray. You can tell it's small because you've got the lines going all the way through. It's in the centre. There's lots of it curling around. You can't really see any air distally, so you can't really see, apart from a bit near the rectum, the large bowel. So just think about where the obstruction might be and what you're expecting to see on the X-ray. Okay, final one. 27-year-old man presents to the emergency department with a 6-hour history of upper abdo pain, radiates to the back, and he's vomiting. He's got lots of epigastric tenderness and a bluish discoloration around his umbilicus. He's tachycardic and he's hypotensive. So these are classic features of pancreatitis. Which one's which? So A is? Yeah, Cullen's. And B? Good. So pancreatitis, you'd see it quite a lot on the surgical wards, even though you don't really do anything surgical about it. The I get smashed, I'm sure, does anyone know what it stands for? What are the big ones in, yeah. Don't quote scorpion bites like I did, because it's, no. So you've got alcohol, you've got, I can't even remember. What else is on there? Yeah, ERCP is a big one actually. ERCPs are not very nice. What was that, sorry? Mumps, yeah, mumps is one. Trauma, yeah. Yeah, so derangement in your electrolytes again, especially calcium. Yeah, steroids, drugs. There's a lot of drugs. Thiazide diuretics, apparently. Things like azathioprine, 6-mercaptopurine, steroids, as you mentioned. They can all precipitate pancreatitis. Just things to think about. Have a look at the drug history. Just think, why are they on these drugs? Could they cause any of the problems they're having at the moment? So gallstones and ethanol, or alcohol is the biggest cause. So symptoms, the pain's very positional, it radiates to the back. They'll be quite anorexic as well. Look for what we said before. So the whole abdomen's quite, so that's why you get the decreased bowel sounds, because you've got a lot of inflammation in your abdomen, your bowel's moving less, it's just trying to keep nice and still. We've covered a lot of that. The test you want to be really looking at, your white cells. Amylase will be sky high. Lipase is also, it's really good, it's really specific and really sensitive. It doesn't tend to get used much because it's really expensive. But often the amylase can be raised and it might not be due to pancreatitis, so you just need to be careful. Think about the results in the context of the patient. You want to be looking for a high glucose, low calcium. These are good signs. And with all your results, you can think about the modified Glasgow score. Does anyone know about that? It's about looking at severity of pancreatitis. And it's quite useful because it uses, what's it called? Pancreas. It all stands for different things. You could probably look at home, but it's looking at oxygen content, it's looking at the age of the patient, white cells, calcium, glucose, urea, albumin, and then some of the liver enzymes as well. So what's it called when you've got words and each bit stands for? Acronym. Is acronym, yeah. So it's a good acronym. So yeah, it's useful to get to grips with. A modified Glasgow score of greater than 3 within the first 48 hours of admission is classified as severe pancreatitis. With pancreatitis, you want to be observing them regularly. You want to be thinking about, from the top, A, B, C, D, E. You want to be thinking about, do they need any oxygen? What's their PO2? Do a gas. It's very useful to get information quickly. As with a lot of surgical problems, it's about fluids. Lots and lots of fluids in the case of acute pancreatitis. And with that comes a catheter, and you might think about an NG as well. And it's mainly a lot of symptomatic relief until you can figure out what's causing the acute pancreatitis. And that's where an ERCP comes in very useful for looking for and sorting out gallstones. If it gets really bad, you can see acute pancreatitis patients in ICU and see them go to surgery for just explorative surgery and debridement of the pancreas. Complications of pancreatitis are probably things to think about. Does anyone know any complications? Yeah, you can get cysts and abscesses on the pancreas, yeah. Yeah, you can get organ failure, respiratory failure, renal failure. Pardon, sorry? Yeah, so the whole pancreas could die. You can get complete derangement in your clotting and DIC. DIC is something I never really got my head around until about a week before finals. And I've forgotten all about it. And then things like chronic pancreatitis as well. Because if you get a lot of pancreatitis, you can progress to chronic pancreatitis. That was a lot of information in a short amount of time. There was a couple of things I just wanted to mention for GI bleeds. Think about Rockall scores and Blatchford scores. Know about them, don't know the ins and outs, just know that they're risk stratification for GI bleeds. That's one thing I forgot. Anyone have any questions about anything? Good.